So good morning, everyone. Today we have Dr. Chintan Doshi to talk about on the management of shaft femur fractures. And Chintan sir, you can take over.
Yeah, hello everyone. Welcome to the OrthoKids module on trauma. And what we are going to discuss, I hope you guys can hear me. Just a minute.
Yes, sir,
Yeah,
you
so,
are audible.
so over the period of next, can you see my slide?
Yeah, it is appeal.
Okay, just a minute. I can't see it. Okay, now I can see. So, over the period of next approximately 3 months, we are going to cover trauma modules alternately with lower limb and upper limb trauma topics. And this is the first lecture on the trauma module on the femur shaft fractures. So we will be conducting we'll covering the entire lower limb from shaft of femur, neck of femur, non-unions, including distal tibia fractures, which are important to manage in children. So over the next 3 months, we are going to have a trauma module lecture every Saturday morning, barring the POSICON meeting Saturday. Otherwise, we have scheduled it for the entire course of next 3 months, covering everything in the upper limb and the lower limb for pediatric trauma. So today we are discussing on how we treat femur shaft fractures in different age groups. As the child keeps growing, we have to change our strategies and change our modality of treatment, what is best suited to a child who has presented to us. So I'll be talking on this by taking examples of at various age groups. So we'll first see those kids which are presenting to us at birth as birth injuries when they're delivered and there are fractures at delivery or within the first year of life. Then we are going to see those which are toddlers, which are between 1 to 5 years, with those who have just started walking and those who have high remodeling potentials. Then we are going to see those which are between 6 to 12 years of age, how the modality of treatment is different, and then going on to the special scenarios and then the adolescent fractures. So let's begin with our first age group, the neonatal fractures or the birth injuries. These can happen. We usually get a call from an ICU or from a maternity home nearby saying that, we have delivered a child, and since the delivery, we have noticed that the swelling around the thigh has been increasing and the child is not moving the lower limb. So we get ask them to get the x-ray done, and this is what we see. It is very disturbing for the parents. For us as a pediatric orthopedic surgeons, we know we can manage this very well. But when these x-rays are presented to the parents or they come to know about this, then they are the ones who are in shock. And it is more these fractures are more to be managed with parents getting managed first, and then over a period of time the child's fracture gets managed and is easily treated. So when we see these x-rays, what are the modalities of treatment that we have at our disposal? uh, and these are the ones, age old method of using Bryant traction or gallows traction, keeping the child admitted for a few weeks in the hospital, and continuous traction which is applied till the time soft callus is formed. Then strapping, Paulic harness, immediate applying of spica or early spica application is seen in some literature. Or then what else you could do? So we'll see all of these one by one. So these are now outdated. The application of Bryant's or gallows traction, where we have specialized pulleys where the plaster is applied to the lower limb or the traction is applied to the lower limb, and the child's limb is kept suspended with the buttocks off the bed. But these are not now regularly followed in our wards because it requires long treatment, and usually this is something that is not acceptable to parents to see their child like this over a long period of time. Other things that we see often from the patients who come to us from periphery are these strappings. They apply this Dynaplast and or a micropore around the thigh, so thigh, leg to the thigh, which gives a good splintage for the femur bone, or thigh to the abdomen. But however, remember that these kids, neonates, they have very fragile skin or they have sensitive skin. Some of these can cause irritation, skin excoriation, and usually these also can be, avoided. You can apply a small tongue depressor or a wooden tongue depressor as bend it to 90 degrees and just apply it as a splint with a soft roll or a cotton bandage around the thigh. That is what I do if we don't have immediate Paulic harness at our disposal. So just immobilize the limb with a soft padding and then convert it to a Paulic harness or another modality whenever is available. So we had this poll opinion since yesterday, and we got these suggestions from most of you as polyc harness. However, some of us also thought the splinting and strapping can be done. Definitely, polyc harness is not universally available, but because of e-commerce and availability on online, now it is very easily you can get it in a couple of days, 2 to 3 days if you order it online also, and if you don't have a good orthotist who makes it in your city or in your periphery. So if it's available, I'll share the link on the delegates group where we have Amazon link for ordering the Paulic harness of various companies. Now everyone almost makes it. I've seen Flamingo, Tynor, Briscoe, all of these companies now have it, and it can be easily ordered even if you don't have a customizable one which is made as per the size of the child. So if you are ordering from an orthotist and you want a well-fitting Paulic harness, then you have to just give them a chest circumference at the level of the nipple. That is how they will. And if you have the length of the baby from head to toe, you just tell them these two measurements and they will be able to make it if they are expert at this. So this kid that we had put in for the poll was managed with Paulic harness, and this went on to heal well. At 2 months, you can see a good bridging callus and bridging bone formation. You would, some of the parents would be worried. So you see a deformity there. Is it going to be staying like that for a longer time? As the child progresses and almost reaches walking age, this is almost always nearly remodeled. Some of them may still persist, but remember these are neonates and these will have a very good remodeling potential and will usually not require anything in terms of surgical management. So all these four x-rays that we saw in the first slide, those all of them were managed with Paulic harness and went on to do well. Looking at the literature, when we search for Paulic harness, almost everything suggests that Paulic harness is a good, comfortable, reliable, and minimal cost treatment for neonatal fractures. Some of the literature suggests applying of early, very early spica, maybe 3 months or 6 months. But most of these cases, up to the age of 6 months when the child is small, can be managed with Paulic harness. Some of them even till 9 months or 1 year, those who are low birth weight babies who are well fitted in Paulic harness can still be managed with Paulic harness. So Paulic harness was first published in literature in 1995, and then all articles after that have been pointing out it to be a better alternative than the other treatment of then followed gallows traction or Bryan's traction and other things. So Paulic harness works well with birth injuries, neonatal fractures, which usually happen if the child has fallen from the bed or rolled over and got an injury. The infant fractures up to the age of 6 months, and as I already discussed, that it can be extended up to 9 months to 1 year in those small babies which are low birth weight and preterm babies. Then we discuss about femur shaft fractures treatment in the next age group, which is from 1 to 5 years. And this is again, we'll see case examples and we'll discuss it over the next few slides. So this is an 18 months old child with a mid third femur shaft fracture. It's completely displaced. There is overlap and not much of rotation, but yes, completely displaced and almost a centimeter of overlap. So these can be very easily managed in spica. A 1.5 spica or a single leg spica can be done for these cases. And once you see a good bridging bone formation, the spica can be removed on fracture healing, and weight bearing can be started as tolerated. So this was another toddler with a similar but a distal third with a long spiral fracture with almost like a varus angulation there on the AP X-ray that we see. This was the one which also we had for our pre-talk poll opinion. Most of us suggested that spica is a better option, and definitely so. uh, some of our senior colleagues who have not been very comfortable with spica, what they have been doing in these 3 years or 5-year-old kids is applying a small Thomas splint, get the traction and the alignment right, see a soft callus formation, maybe convert it into a Tobruk cast, wherein you roll the cast around the Thomas splint and keep it till the time the bridging bone is formed, and then remove the cast and start weight bearing. So that is what Thomas splint initially and then cast means. And then usually these cases would rarely require any other operative intervention. Once the spica is applied, the same child was applied in hip spica. They're very comfortable. So this is direct picture from the ward. The child is happy, comfortable, lying, very easy to nurse. There is not much movement of the fracture. You have left enough space in the perineum where it can be cleaned, and the child is happily playing on the on the phone. So the same child at 10 weeks follow-up shows very good healing, and the weight bearing can be started uh, when the spica is almost removed at about 1.5 to 2 months. So management in spica also covers the topics where how to give the spica and what position the spica should be given, and how early would you do check X-rays, and how much on repeatedly check X-ray will be done on follow-up. So spica position is dependent on what the fracture is. So if the fracture is in the proximal third of femur, there is a force on the lesser trochanter of flexion and abduction. So the proximal femur goes into flexion and abduction. So in these cases, you may have to give up to about 30 to 45 degrees of hip flexion so as to bring the distal fragment in alignment with the proximal fragment, and maybe some degrees of external rotation in this case of proximal third fractures. In mid-shaft fractures, usually 30-30 and neutral rotation works well. Sometimes in older kids, you can also, if the fracture is not so much displaced, you can just do it in hip in extension so as to make it comfortable, as we saw in the previous child's spica cast. Then check X-rays. It depends on how the displacement is and how much you uh, expect it to displace in the spica, and whether it is a well-fitting spica or not. So usually at 1 week to 2 weeks time, I'll do a first X-ray. So because the swelling will reduce and there may be some increase in overlap or increase in displacement. If it is acceptable and aligned, still I would not change it, but it all depends. I would not accept a varus of more than 20 to 30 degrees because that takes a very long time to remodel. So also when we are applying and the position that we are doing the spica in, we always give a valgus mold, because varus is not something which is well tolerated on walking, and it produces Trendelenburg gait for a very long time. So usually a bit of valgus mold. So even if the displacement is going to happen within the cast, it will come back to the neutral position, and not too much of valgus also. So sharp femur in less than 5-year-old, we have spica which works well. We get alignment, acceptable reduction, and a well-fitting spica. Again, when we look in literature in this age group, there's a systematic review of spica casting to treat pediatric diaphyseal fractures of less than 6-year-old, and it suggests that when we see the complication rates, most of these almost 8% of these are only the skin complications. So if the spica is maintained well by parents, it is hygienically maintained well, then those that are soiled with urine or stool would have skin excoriation or skin ulcers. But if it is maintained well, the edges are well padded, then usually these complications are very well taken care of. The other complications of shortening or angulation or need for wedging, or the chances of refracture, they are very less, almost less than 1%. So and these are almost more than 1,000 cases, a systematic review of multiple literature since 2002, 2000 to 2016, that they have looked into, and it is pretty much okay to accept this kind of complications if it is less than 1%. What is acceptability criteria for accepting the shortening and the angulation? So as we already discussed that varus of any degrees is less accepted, but valgus is very well accepted because varus will produce a long you know gait abnormality which will be seen as a child is walking. Shortening up to 2 centimeters in less than 6 year old is very well tolerated and gets almost adjusted with the height as the child grows. But as the child grows beyond 6 to adolescent age group, this acceptability criteria comes down to almost a centimeter. So that is where you have to be careful when you're treating the older children. Single leg spica is an option apart from that 1.5 spica, those two cases that we saw. And in undisplaced fractures or in a stable fracture pattern or in the midshaft fractures or distal femur fractures, single leg spica would work well. However, in the proximal third, where there are forces on the hip, still a 1.5 spica is preferable. Those that are unstable, also 1.5 spica is favorable, so that not much of pelvic movements affect the displacement within the cast. The other opinion that we saw during our poll was the tense nailing in age group less than 5 years or less than 6 years. Is it safe? So there are literatures which suggest that there is no complications or there is no other factors that are affecting except the fact that the small child is going under the knife. So these literatures are mainly European, and most other literature suggest around the fact that spica would work well when compared to a tense nailing. Then we look at the other age group, which is more active, more involved in activity of running, sports, and other things, and which would have presented to us with femur fractures between the age group of 5 to 12. And these are the usual X-rays that we get presented with. A 5 year old with femur shaft, this looks like a 8 year old with a femur shaft fracture with almost an overlap of more than 2.5 centimeters, almost an inch or more. So these are very well treated with tense nailing, and a well operated case would usually go on to heal well and give you a good result. Another case, okay, there where the fracture reduction is very difficult, we have our accessibility to F tool on in the set, where you can get a good reduction as seen in this Siam picture, where a F tool is used to get a reduction, and then one nail is passed and then the other one. So this is the post-op X-ray of the same patient with a 3 weeks follow-up. Then we go on to see some other scenarios where we would use something different. So this is another a 10-year-old boy with history of fall while cycling and got this nasty femur shaft fracture. The middle fragment, the it's a long spiral with a long butterfly, and the middle fragment is almost 1/3 of the shaft of the femur, and these are what we call as a length unstable fractures. So this also we had it for poll yesterday night, and most of us would do TENS but would augment it with something else. So TENS with X-fix or TENS with a cast, or just augment it till the time the healing is happening, and then you can just keep the TENS in for a longer duration. So these would help uh, for doing this. So as suggested on the poll, we did tense nailing with external fixator. Okay. Other things that are available on the set, not all companies do have it, but then these are the end caps. You can see on the lateral nail that has been passed, we have an end cap. This also helps in length and stable fractures where it does not allow the the length to collapse and keeps the length maintained. So if you have end caps on both the sides and it is quite stable and well fitting fixation, then probably in this case just a plaster would do and you could have avoided a external fixator at the same time. So this went on to heal well. Now when we are doing uh, augmented TENS, that is a hybrid TENS, we remove the external fixator at about 4 to 6 weeks when when you see a good soft callus and good bridging callus which is formed, and the patient can go on to weight bear, and at about 2 to 3 months you will see that it has healed well, and this is the clinical pictures and video of the what the child can do at about 4 months. The same patient, a similar patient for which the hybrid fixation was done, also healed well. And this is 1 year follow when he came for implant removal. And then these are the clinical pictures of the same patient. Another scenario where length unstable fractures, but these fractures are in the distal third of the shaft. And these are the, you know, diaphyseal metaphyseal junction, and you in this fracture we don't have enough room for the TENS. You could do a retrograde TENS, you can do it from the proximal fragment, but again there is a bone loss, there are multiple fragments, lot of comminution. What is also acceptable is to do a bridge plating. Okay, you can just slide the plate along the femur, just bridge the fracture site and use it to stabilize the fracture and then remove it at about 1 year's time. So went in the literature to see. So these are the options that are available to do TENS with end caps, TENS with hybrid fixation, or submuscular plate to maintain the length of these, length unstable fractures. And when we compared the, using of elastic nail versus plate, then it almost has a similar result. There's another paper from our Mumbai group where they compared use of external fixator with nail and bridge plating, and both of them usually, there was no change in any post-operative range or functional or any other criteria. So everything was very well accepted. So both of them are good. So no problems if you even do a plate instead of doing a hybrid TENS. So these are the techniques that are at our disposal, where you do a diaphyseal femur shaft fractures between 5 to 12 years of age. You could do tensional or submuscular plating if it is stable. If it is length unstable, again submuscular plating works well. If you're doing a TENS, you would augment it with external fixator or a plaster. Pathological fractures, usually those with a cyst, those with fibrous dysplasia, those with osteogenesis imperfecta, usually the intermedullary nailing works better. And those with osteogenesis imperfecta usually would have a telescopic nail, which we cover it in the subsequent talk. Then the metaphyseal fractures, which are closer to the physis, either the proximal or the distal, where you don't have much of room for the tensional to hold a smaller fragment. In those cases, plating is preferred over nailing. Then we see the next age group, which are the adolescent age group with femur shaft fractures. So adolescent age group, what are the what are the implants at our disposal? Again, tensile and bridge plating. If the tensile, if the weight is less than 50 kg, or a submuscular or a bridge plate does work well. Other things that we use is conventional femur interlock nail. So if you have a good roomy intramedullary canal, and the child is almost 14, 15, 16-year old, then conventional femur interlock starts from 9 millimeters. So if you have a good canal, then that is one that works well. Those around 10, 11, where the canal is 6 or 7 or 8 where a conventional femur interlock might not be a good implant to put in. Adolescent femur nails, which are available from the diameter of 6 to 9 millimeters, can be used. And similarly, humerus nail are also available in 6.5 and 7.5 millimeter diameter. So those with small canals can, we can do a humerus nail as well. So this case of 14-year-old girl with who had fall while skydiving, and while landing, the foot got stuck, and she sustained this femur shaft fracture. So we had this for poll yesterday again, and most of us were between this conventional femur interlock nail and adolescent femur nail. So definitely both of them are the proper, methods of treating them. Tense nailing not so, because we discussed that this kid is about 56 kgs weight. Another thing is, in this adolescent age group of 14, 15 years, there are a lot of muscle forces. Usually, if tense nails are not well done, then there will be bending or varus. When the child starts walking, there will be varus at the femur side. There are chances of bending of nail within the canal because of the weight. So adolescent femur nail. So this case we did adolescent femur nail, and this was almost a decade back when we had first introduced the adolescent nail. This is with the flutes where it easily passes through. You can see uh, the design on the CM views, and this is almost, I think, a 7 millimeter nail. So it passes very easily in the narrow canal. And then this was a post-op X-ray, and this went on to heal well. Our group, our senior doctor, Dr. Venkat Das from Ganga, has published this, where because of the availability of adolescent femur nail is not so easy, because only few companies make it. A conventional femur interlock nail in this adolescent age group does work well. Only the concerns are we are going very close to the blood vessel which is supplying the head of the femur, and because the entry of these conventional nail is through the piriformis, because it's a straight nail. So but in his paper where he has this 14-year analysis, none of the case had suffered an AVN. So it's a good thing to cite, but that is what is in the international literature. That is what is the one, that is why we are not using a conventional interlock nail in younger age group. Another thing, good thing about this is because it is widely available, almost every other company would make it, and it is a routine procedure. There is no change in entry point. It is easy to go and fix this fracture. So, uh, femur fractures are very common in children. Treatment of these fractures depend on the age and the type of fracture pattern. We don't over treat this, so no, it doesn't make sense to putting tense nail for a very young child of 2 years or 3 year old if it can be easily conserved. So do not over treat it. Those that can be easily conserved should be conserved. Don't under treat them. So those which are older patients where there is a varus deformity, it is grossly displaced, which might not remodel over a long period of time and would give you problems of deformity, or deformity correction would be required, then do treat them early in these cases. So femur shaft fractures age-wise, if we see in infant or neonatal fractures, we have Paulick harness and strapping as our options. Toddlers, spica cast works well. However, Thomas splint followed by cast is also a good option. Young child who is above 6 years but less than 10 to 12 years, tense nailing does work well. In those length unstable fractures, we have submuscular plate hybrid fixation and tensioning with plaster as an option for us. In adolescent femur shaft fractures, intramedullary femur nail does work well. So a conventional interlock nail or a adolescent femur nail, or you have a plate at your disposal, then a submuscular plating or a bridge plating also is a good option. So thank you for this. And we do have a case to discuss. I don't know if Vaibhav or Vipin.
Yeah.
Yeah, so we can take the questions as well, and you can prepare for your case. I think you have a case to present, right?
Yes, sir. So excellent talk. I wanted to know, are there any indications of operating under 5 years of age for shaft of femur?
So yeah, so there are few indications. So if you have a femur shaft fracture with a neck of femur fracture, so neck of femur fracture, you're anyways going to operate and fix it. Then at the same time, because it's a ipsilateral, same limb, same bone involvement, to stabilize the distal fragment, yes, you could put a tense nail and do the fixation for the neck of femur fracture. So ipsilateral concomitant another fracture which would need a operative intervention, you would, fix this fracture as well, because that will give you a stability of the entire length of femur then. Other thing is not usually, but yeah, compound fractures. If you want to, do wound debridement, have a X fix, that would work well. But then most of these are very well treated in spica. So even if in that case you're doing, once the wound is healthy and you can apply a spica, then you would remove the fixator and do a spica then early. So that is what would be.
And what about pathological fractures, like under 10 years of age? Anything you
Uh,
would like to fix
Again,
also?
again, pathological fractures involving proximal femur, so a subtroch or a cyst near the intertrochanteric region, or a neck of femur where there is going to be a weakening of bone, and which will lead to a fracture. In those cases, yes, but if it's now it's a simple bone cyst in the shaft of femur or the distal third shaft, I would still go ahead with applying a spica, allow it to heal, because the fracture itself here is going to heal that cyst. So if it's a simple bone cyst, if it's another pathology, like if it's let's say a osteum imperfecta, okay, there is a gross deformity, the child has had sustained about 8 to 10 fractures since the birth to the fourth, the child is 4 years of age, and put a rush nail with correcting the deformity, definitely it does, we can do that. And in fact, it is better that we to prevent further fractures and further suffering, doing a early rush rod or a telescoping nail whenever suitable for the canal, you can do that. So pathological fractures, yes, definitely, but limited indications.
So we have a question, like uh, someone wants to know the technique, like X6 and hybrid for hybrid fixation, X6 followed by tens and traction, or like tens followed by X6.
Okay, so I don't have a video, but putting a 10 snail. So I'll put, we'll have a lecture on video techniques in low limb trauma module. So I think I had a space to adjust one more lecture. So I think we can do a 10 snailing and some other neck of femur fixation videos. So I'll try to put that. But yeah, so doing the 10 snail. So when we are doing this length unstable fractures, what I would do is first put in a 10 snail, because putting a X fix and then getting the tensional in that canal will be a little tricky. So put the tensional first, get the uh, fracture stabilized with a tensional, and then to maintain the length, just put two pins proximally, two pins distally, miss the nail technique, and then connect it with a connecting rod. So it will not be X fix followed by tens. It will be tens first, then putting the X fix just to maintain the length. Again, the X fix will come out first, because at 4 we want range of motion. We want the child to get full knee flexion. We want the child to start doing everything. So once you see a soft callus or a callus formation, we'll remove the X fix, start weight bearing as tolerated, and then the tensile will be removed maybe at 9 months or 1 year of age. And traction followed by tens followed by X fix. So same thing. So yeah, to maintain the length, you would to do a Thomas splint. Whenever early you can go in with putting of tens and X fix, you can do that.
So next question is there any role of high groin slabs instead of spica?
Yeah, so there is, if it is a distal third fracture, we see distal third femur torus fractures around the diaphyseal metaphyseal junction. In those, high growing plasters or cast or slabs would work well. Those that are proximal third, your even high growing plasters will end somewhere below the lesser trunk, because lesser trunk is where the growing trace would be, somewhere near that area. And then those fractures which are very close to the lesser trochanter or the proximal shaft of femur, then they will have angulation, they'll have varus, they'll have deformity, because your high groin cast will end where the fracture site would probably be. And then that will lead to varus because your lower part of the plaster is straight, and then the proximal femur has the pull of flexion, abduction, external rotation, and then that'll have give you a long standing deformity. Obviously it will remodel to some extent, but in those cases spica is better. But high groin cast does have a role of management if we have to do it.
Now, also, how do we prevent rotation and subtrochanteric fractures using TENS?
So a tense, we'll cover it in technique part. So tense, if applied well, if it is, the nail, the elastic nail is occupying 80% of the canal, two nails are occupying 80% of the canal, they are adequately bent, they are, holding the fracture with good 3 point fixation, then it is by technique and by principle, it has all stability. It has rotational stability, it has axial stability, it has translational stability, and even collapsible stability. So usually if it is applied well, then we don't need to, it's not going to change the rotation from what you have done intraoperatively. So another thing, if you want to prevent rotation, you can do, after tens and you are worried that, it is a thinner size nail, the canal is roomy, and you want to prevent rotation, you can put in a spica along with tens that will prevent the rotation. And X fix, as I said, if you are not sure of the stability
Yeah.
with only tens, you can do hybrid with spica or with a X fix. Again, till the time soft callus is formed, when the callus is formed, it's not going to change rotation. So then you can just take out the X fix.
So, do we change position in hip spica according to the fracture site?
Yeah. So why change position? So the thing is, in proximal, now most of those cases that the X-rays that you saw, in a mid-shaft fracture, it is usually very well aligned. There is the forces of proximal femur are well neutralized with the forces on the distal femur. However, in the proximal third or the fracture which are below the lesser troch and very close to the proximal third of the shaft, what is happening is there is a very high pull up iliopsoas on the lesser trochanter, external rotators and abductors on the greater trochanter, and that will bring the proximal fragment into more of flexion, external rotation, and abduction. Now, if we are applying spica in extension in this case, not giving that approximately 30 to 45 degrees of hip flexion, what is going to happen is it's going to unite. All these fractures will unite. There is no problem with union in femur shaft fractures usually if they are not operated, but it will unite with a deformity, and this will take a very longer time. You have seen when when these cases are coming to you as a second opinion, usually the child will come with a bow in the anterior femur, which is almost palpable anterior thigh or a lateral thigh, and they have a varus or a anterior increased anterior bow. It does remodel as a child grows, but usually it takes about 3 to 5 years, a longer time, and they are walking with an abnormal gait. So spica position depending on the level of the fracture is very important.
So, do you have any experience in operating in osteopetrotic fractures, like in a patient with osteopetrosis?
So not as such, but usually osteopetrosis with shaft femur fractures is actually very common.
Yeah.
You don't have room for tens.
Mm.
Okay. Uh, those you can do a submuscular plating. So these are again, if they are less than 5 years, I will do a spica. Again, no fixation. More than 5 years, or somewhere there 8 or 10 year old, then it will be a plating with again multiple drill bits you have to keep, because in osteopetrosis you'll have the drill bit will be broken drill bits are a very common phenomenon. So you have to be having, your armamentarium to, put in a plate properly. But again, here, not like adults, you need just two screws proximally, two screws distally, just to stabilize it. After that, you can put in a slab for some time. Once the callus is seen, remove the slab, start weight bearing. That should be okay.
So rest questions we can take on the WhatsApp group.
I am not on the WhatsApp group. I'll just see. So does spiker position change? That is done. Okay.
Sir, after the class, we can take those questions.
Okay, after the class. Okay, no
Yeah.
problem. No one has
Yes.
asked yes, search. Yeah, but you can, if anyone has any
Yeah.
question, they can just put it on the group and we'll discuss it during the course of the week.
So I think I
So
can
you're
start
presenting
with
a case, right?
yeah. So
Yeah.
I can share my screen.
So those who are attending, next week we'll have a trauma upper limb module and the details will be shared by Vaibhav in the coming week. So every week there will be some topic on trauma and we'll be discussing it at length. You can share your screen, Vaibhav.
Yeah, sir.
Anyone has any other case to discuss? I think Vaibhav is the one who volunteered yesterday to present a case. Any difficult case or any abnormal presentation? Maybe a pathological fracture, maybe a concomitant neck or femur fracture.
Okay, so I think I lost my connection. Am I audible?
Yeah, you're audible, but we can't see your screen.
Yeah.
You can share screen.
Yes. Is it visible now?
Yeah, now you can see the screen.
Yeah. How do I- So this we are going to talk about a case of osteogenesis imperfecta, a 16-year-old male, and he was our regular patient. Currently, he presented with a trivial injury, as they usually do, with a complaint of pain and deformity right thigh and inability to bear weight. And there was a procurvatum deformity of the distal thigh. So this was the X-ray. As we can see, there's a distal third metadiaphyseal fracture of the shaft femur, and there's a telescopic nail in situ. So previously, this was done by us only for subtrochanteric fracture. Yes. So he presented at the age of 13 years old, 13 years, with a subtrochanteric fracture of the ipsilateral limb, which was fixed with a telescopic nail. Until then, we did not find any change in the neck shaft angle. It appeared to be all right, but he was followed up, and these are the follow-up X-rays, and the fracture united well. But then we started noticing the coxa vara. This neck shaft angle is significantly reduced, and uh, this fracture united well. And currently, with coxa vara, we have this distal third fracture with implant bending. And as you can see, the fracture is at the level of the end of the female rod. So probably the end of the female rod uh, acted as a stress riser. So currently we have issues of distal femur fracture. This patient was skeletally matured, and We had issues of rotational stability with this nail, telescopic nail, and again, coxa vara. Do we treat it simultaneously, and what should be our implant choices? So, sir, any opinions? Hello, Chintan sir.
Uh, so yeah, so this phenomenon is that nail walking out is common because there is the bone is weak in the proximal femur, and the nail tries to walk out, and then you see a vara at the neck.
Hmm.
That is one. The other thing here challenging is, even if you have to remove this telescopic rod, there is the bend at at the junction of male and female rod. Probably it may not be very straight to just pull it out. Uh, let's see. But once you take out the female rod, then the male rod, I hope it is not broken there, because if that segment remains inside, then it's trouble.
So, how do we plan it, sir?
So you need. So what you need is, you need stable fixation at the distal femur. One. Second, you need to straighten that onto there, and maybe the coxa vara can be tackled later. So
Could you mute Rishi?
okay, done. So yeah. So maybe tackling everything at the same time, I would avoid. Maybe I would just, allow the distal fragment to heal first. I'll remove this nail. If there is a room for a adolescent femur nail, I'll put that. Uh, Also, in adolescent femur nail, you have room to put the neck screws. Okay,
Yeah.
so if you're tackling the coxa vara, then those screws will be helpful there. But if you're putting the nail here, another thing is how much of the working length you're gonna get, because the distal femur fracture is the distal fragment is too small here. You may just get a like something like a tip locking nail, like you can just
Hmm.
lock it at the last screw, last bolt, you can get that. The third bolt you might not get because the fragment is too small around that area.
Do we augment it with the plate?
Maybe I but again, osteogenesis imperfecta, as I already discussed in the talk, doing plating in pathological bones is not advisable. Okay, there are stress risers at the end of the plate, and there will be another fracture. In next 6 months, the child will come that the fracture has happened at the end of the plate. So plating is not a good option in osteogenesis imperfecta. Maybe a 10, if there's no room for adults. See, the canal is very narrow in these children.
Hmm.
Maybe just remove this telescopic nail and put another telescopic nail in straight position would be my treatment of choice in the first go. And then once the canal has good diameter, then do the coxavara correction and put a adolescent femur nail at maybe in the future. So that is what I would suggest. I don't know
But
whether there
sir,
is so much room to put another nail, or a adolescent or a femur nail in this case. I don't know. It
but
would narrow.
what about the rotational stability? Telescopic nail won't do that.
So we do telescopic nail. We do multiple osteotomies.
Yeah.
When you're doing a deformity
Hmm.
correction of osteogen imperfecta, with telescopic nail, we just do a cast, right?
Okay.
We don't do plating
Hmm.
as such
Hmm.
unless it is grossly unstable. And this doesn't look to be. This is just a if you just correct it and put in a cast with a new telescopic nail, I think that would do well. Like my treatment of option. If there is
Okay.
a room, then I'll put a nail, adolescent femur nail. If there is a good
Adolescent
room
female.
in the canal, then yes, more than six
But with
millimeters. If you have a space in the canal, then adolescent femur nail will work well. But you have to have both the options on table ready.
and what about the neck? Because if we put the neck screw, they will be at a fixed angle. That is
Yeah.
approximately 130 degrees. But the
Yeah.
next neck is in varus. We won't be able to put
Right.
neck screws.
So in adolescent femur nail, you'll have a shaft screw also and a neck screw
Yeah,
also.
yeah,
You have an option to correct coxa vara at the same stage. So probably at, you know, you can just have the entry point of the nail on the tip of the
okay.
greater trochanter and get that valgus if possible. But then that again tackling two osteotomies with a interlock nail, I think. So as I said, I would just do one fracture at a time, do a
Okay.
coxa vara correction later.
Hmm. So we did something different. We
Okay.
basically dared to correct it simultaneously. And the
Okay.
options we thought of was a nail plate construct. And then we had a question which nail to use. Again, a telescopic nail again, or a humerus interlocking nail, or a adolescent femur nail. So for that, we planned, and again, modified Wagner's subtrochanteric osteotomy was a thing we had in our mind, or we thought of a retrograde femur nail with minimum 9 mm diameter till isthmus, and then augmenting it, doing a subtrochanteric osteotomy, and uh, fixing it with a proximal femur osteotomy plate. Then our last option we thought of was a subtrochanteric closing wedge osteotomy and fix it with the antegrade nail. So these were the thoughts. This is a paper on by Faziar published in JPO 2008, and they used to do modified Wagner's osteotomy, and by passing two K wires in the neck, these are anterior to posterior K wires and posterior to anterior K wires, and a transverse subtrochanteric osteotomy was done, and then valgus was achieved. Then lateral cortex was reamed retrogradely to make another entry for the canal. And this fragment was medially translated. A wedge was removed from the distal fragment and a nail was inserted. And these K wires are bent over the cortex and stabilized with SS wires. So this was modified Wagner's. We thought of it, but we thought if we again put a telescopic nail, the child is skeletally mature. We won't be able to get rotational stability at the distal fragment. So okay. Then we planned the length of the femur radiologically and clinically was about 36 to 38 mm, and the radiographic canal width at the isthmus was 8 mm, and we calculated the valgus needed. So that was about 25 degrees of correction. We thought of this adolescent recon nail, which starts from the diameter of 6 mm, trochanteric entry, and we chose subtrochanteric lateral wedge closing osteotomy and thought of going transphysial when passing the nail to get 3 interlocking screws distally. So this is the post-op X-ray. After extracting the nail, we were fortunate enough to extract the nail without opening the fracture site. It was pulled up and it was extracted easily. Then we exposed the subtrochanteric region. We did a closing wedge medial open osteotomy to get our desired neck shaft angle. Fixed it with a adolescent femur nail, trochanteric entry. And again, as you can see, the neck screw was passed intentionally through the physis since it was a skeletally mature child. And also, we don't want any chance of a physial slip later on. And distal fragment was well aligned on the AP and the lateral view. So we were able to convert a 112 degree of neck shaft angle to a 136 degree with this nail and expect this osteotomy to heal well. We did it last week only. Yeah. So, sir, any comments?
Yeah, that's good. Just got away with that third screw near the fracture side.
Yeah.
The two screws would have been enough. The third one is very close to the fracture side. Maybe a splinter may, but rest of it, excellent. Good. Because
Basically,
both you tackled everything at the same stage.
yeah.
Good.
And basically we are managing this on a slab right now, at
Yeah.
least till we get some union at this.
Healing and callus, right?
Yeah, exactly. So this was my case.
Right.
I think we don't have any more questions right now. So rest of the questions can be answered on the WhatsApp group. And thank you, Chintan sir, for this excellent talk. I think we should conclude.
Yeah. We are nearing 9 o'clock now.
Yeah,
So good. I
right
think we
on
have
time.
an hour for femur shaft fractures.
Okay. Thank you everyone to join us. We will be doing alternate upper limb and lower limb trauma every week. And next talk is lined on next Saturday. That will be on lateral condyle fractures.
Okay.
Yeah. Okay. Further information will be given on the WhatsApp group itself. Thank you, sir.